Okay, questions about content. That's what today is really about. Yes, sir.
I thought about this, and this is how I'm going to go with this question. A year from now, if you bump into one of us, who knows where, and we say, we really love that 393 course. We learned so much. In particular about ethanol, barbiturates, and benzodiazepines, so-and-so. What would those three things about those three things be the most important things that you would have hoped we would have kept a year ago?
It's a good setup. Okay, what's the organizing? That's a great question. What's the organizing principle that ties these three drug classes together? Pharmacological, pharmacodynamic reality.
GABA.
They all operate at the GABA receptor. Wow, isn't that interesting? These three very different drugs are all operating at the same receptor. I think that's pharmacologically very interesting, fundamental, because it has all sorts of implications. So what does that mean? If you're dependent on and tolerant of barbiturates, what does it mean about ethanol? Yeah, you could have cross-tolerance across these drugs. If you are in withdrawal from ethanol, you might be tempted to take one of the other drugs because they're all going to operate at the GABA receptor. So I would say a fundamentally important thing is they're all operating at the GABA receptor. I find that interesting. Why are we sensitive to these bizarre drugs that are not endogenous? We don't have endogenous ethanol, we don't have endogenous barbiturates, we don't have endogenous benzos, right? Next unit, we have endogenous opiates. We make our own heroin. Thankfully, not quite as potent. Heroin in quotations. Okay, but we don't make our own benzos, we don't make our own. Why are we sensitive to them? Because the site is normally occupied by? No? GABA site's not occupied by these drugs.
Endogenous
Well,
compounds.
For benzodiazepines, isn't it beta-carbolines?
Beta-carbolines. So these drugs are fortuitously, fortunately, going in and occupying the site where the, oh crap, I'm scared endogenous compound goes, the beta-carboline. The beta-carboline freaks us out. Barbiturates, ethanol, and especially the benzos go in and take that site, but have the opposite action. So clinically, those of you that think that way, what would we expect to find in people who are dealing with generalized anxiety disorder? What might be really high in their brains? Beta-carbolines. Thus, why do we give them benzos? To displace the beta-carbolines.
So they have a higher affinity?
It was what would we expect. Don't quote me on that. But I'd be real surprised if it weren't the case, that people with generalized anxiety disorder don't have higher beta-carboline levels. But I didn't look it up. Okay, so you got two things. Almost universal significance of GABA receptor, the fact that we're sensitive to these drugs because we're normally responding to beta-carbolines. Within these three drugs, one of them is safer. Why? Which one and why? Benzos, because
They can't act together.
my work here is done. Yeah, benzos can only facilitate GABA. They can't operate that chloride channel on their own. Ethanol can operate chloride channel its own. Therefore, if you just keep drinking more alcohol, you keep getting more and more depressed. And by depressed, I don't mean sad. I mean dead. Barbiturates. You take more and more barbiturates, you keep shutting down function. More and more depression. Benzos. You max out your benzo levels, and then you take twice as much as you just took, what happens? If you've already maxed them out, you're using all the using all the GABA you have, and I take more benzos, what's the effect? Nothing. That's why the toxicity, that therapeutic margin, is so huge in benzos. 20,000 to 1. It's really hard to OD on benzos.
I had a client when I worked with people with developmental disorders that had actually OD'd on Klonopin at one point, and it was just Klonopin. I don't know how many she took or anything like that, but how was that possible that she OD'd on them? She didn't die, obviously, because she ended up being a client, but she did end up forever just kind of stuck within herself. It was comparable to somebody with cerebral palsy, but she did not have cerebral palsy. She had OD'd at 14.
Hold on. Don't have an easy answer. I wanted to double check the half-life in pharmacology for a second.
Could she have had a stroke?
Well, that would make sense with the cerebral palsy symptoms.
I don't have an answer based on that amount of information. I mean, just because it's safe doesn't mean, just because it's safer doesn't mean it's safe. Right, so you give me a choice between giving you phenobarb and giving you Valium. No question. I would far rather see someone on Valium, short term.
It's just the LD50 does 20,000 higher. It's not.
Well, that's the therapeutic margin, exactly.
Yeah.
Yeah. So the LD50 is just huge, but good
You can
point.
still have all
There
sorts of
is an LD50,
Yeah.
which means it can happen. Yeah. But it is safer. It is a preferred anxiolytic. Well, actually, it's not the preferred anxiolytic. What's the preferred anxiolytic? Buspirone. Yeah. Because it's leaving the GABA receptors alone completely and operating through shutting down hyperactive serotonin and doing this cool peripheral thing.
What's the trade name for Buspirone?
Buspar.
How come, have we seen ads on TV for that? Because usually if something's this good, it's all over the evening news.
It's been around for a while.
Yeah.
I'm pretty sure the patent's expired.
Okay.
I'd have to check the FDA
Oh, so
site to
definitely.
see. Yeah, it's not new, and it doesn't change your sex life, so.
So why would we care? Yeah.
SSRIs are hot and sexy, and everybody wants them, and then ED drugs are ED drugs. But if it's out of patent, it's not profitable. You're getting it at Walmart for $4. Yes?
Can you explain the pharmacodynamics of the non-barbiturate sedatives?
It'd be a waste of your time.
Okay.
There's enough in the barbiturates, ethanol, and benzos, I think. And they're a weirder class. Though, oh God, what did I just read? The graduate seminar, someone brought in a paper on, oh, I'm blocking on the name of the drug. I've never heard of it. I get this. So on non-barbiturate sedatives, this drug was chemically modified. Ether. Very contemporary. I mean, like right now drug that's ether. Folks, we haven't used ether as an analgesic since like the Civil War, but it's what it is. It's a modified form of ether. And I have never looked at the pharmacology of ether because why would you? I was pretty, so by next time I teach this, I'm going to have to change my position on the non-traditional sedatives. But, yeah, so don't worry about this. Patrick, did I answer your question about what I would want to find out about?
Yes.
That's right now.
Yes.
I think we've got some really cool, hot, sexy drugs coming that are going to trump barbiturates. You're going to be far more intrigued by the cannabinoids and the opiates and the hallucinogens are cool. They want to talk about depressants.
Would there be any value, as we were learning about hypnotics and reading about hypnotics, I kept going back in my head to the over-the-counter doxylamine and diphenhydramine, and I wondered how they differed in their action. Like, do those even deal with receptor sites? They're
All the over-counter antihistamines, right?
yeah, exactly.
They're anticholinergic.
Yeah.
So their mechanism of action doesn't involve neuronal receptor sites and such?
Yeah, they do, but they're not on the GABA receptor.
Aha, and that's why we don't care about it.
Well, no, it's just not what we talked about.
Okay, but that's the differentiation.
Yeah, stay on the GABA receptor. That's probably what I should have called this unit, the GABAergic
GABA
depressants. Can get that old cowboy. None of you guys are old enough to know him.
Gabby?
Gabby.
Yes. I'm not old enough either, but my mom talks about it.
He could be the icon for this unit. GABA Hayes.
And you said we're studying cannabinoids in the next section. Aren't those a depressant as well?
Cannabinoids are their own class. They have depressant qualities, they have stimulant qualities, they have hallucinogenic qualities, they have anxiolytic qualities. They have appetite stimulating qualities. Cannabinoids are just wacky. They're very cool. We'll warm up with the opiates because they're complicated, and then attempt a 3.5 full twisting dismount to the cannabinoids because, man, they're everywhere. And we have endogenous cannabinoids. We make our own.
Are they called endorphins?
No,
What are they
those
called?
are the endogenous opiates.
Oh, yeah. What are they called? Are
Endogenous cannabinoids.
Okay.
And guess what they do to you?
Good high.
No? This is so funny. The endogenous cannabinoids, why do we make them? What system do they modulate?
Hunger.
Hunger. The munchies are real. That's, of all the things we experience when we take THC, the hunger is the natural response.
One of them is called, it starts with M, right? Starts with M, and then the other one starts with D. I read it in my article for my paper. I know what you're talking about. Something like that. I know what you're talking about. Because it's for AIDS patients and cancer patients. For AIDS patients in their anorexia.
Okay,
Yeah,
that's not this
what it's
unit.
called.
Marinol?
Yeah. For real.
Where are the GABA receptors structurally in our brain? Are they all over?
Distributed profusely.
How many are there?
How many?
One of them numbers, man.
Something less than all the grains of sand on all the beaches of the world. I couldn't even begin to tell you. Now, the one thing we do know is there is one unique distinction about a particular subset of GABA receptors that are almost entirely central. Thus, this drug would be only active centrally. Anybody remember?
A, GABA A.
And receptor sites on, so the GABA A's are more diversely, but the GABA A's with benzo sites. Benzo sites are central. You can find GABA receptor sites in the periphery for that have ethanol binding locations, barbiturate binding locations, but benzos seem to be specifically central. They're only in your brain.
Is that what you mean when you say central?
Yeah.
I thought you meant even more central. but-
No, central, as in the brain.
Okay.
Yes, Joe.
You said benzos or specifically what?
Central brain. Bless you.
What does ethanol do with the glutamate receptor? Besides act as an antagonist. I have something in here about calcium.
Yeah, it blocks. Double check. But I believe it prevents calcium from entering the presynaptic membrane. Anyone who's ahead of me and wants to say yes, feel free.
What does ethanol do with the glutamate receptor?
Glutamate receptor, voltage, C plus receptors, and
Say it again.
binds antagonistically in the glutamate receptor, the voltage-gated C plus receptors.
Yep. That's what I said, right?
Hyperexcitability.
Yep. Wait, does what?
During
Binds at the-
during withdrawal, we see hyperexcitability.
Okay, that's because in the absence of the alcohol. So it's going to bind a presynaptic membrane that would normally admit calcium. Calcium is positively charged. No, sorry. Yeah, so it binds where calcium would come in, but prevents calcium from coming in. Therefore, it's harder to generate an action potential. Because you need the calcium to potentiate the neurotransmitter release. So sorry, let me back up and do that again. So you got the terminal arborization, and you've got receptor sites on there that normally admit calcium. Calcium then causes the neurotransmitter vesicles to fuse and release the chemical into the synapse. In the absence of that effect, what would happen? Nerve activity would go down. Thus, in the absence of ethanol, you're admitting, because you've upregulated that process to compensate for the ethanol, so now when I pull the ethanol out, you're emitting too much calcium, releasing too much neurotransmitter, and you are hyperexcitable.
I have, it's inhibitory without GABA involvement. What does that mean?
Okay?
Inhibit voltage-gated calcium
Yep.
channels.
So visualize your GABA receptor.
Right.
Big, huge, giant hole in the middle that would love to let chloride in. Normally opened in response to GABA. Ethanol opens it on its own.
Oh.
Barbiturates opens it on its own. Benzos open it
With GABA.
through allosteric modulation.
Okay.
I change GABA's function from nearby. So imagine it this way. Here's the opening, which is closed. Closed. Okay, good. I'm an ethanol molecule. I bind on at the ethanol site, and it opens. I'm a barbiturate molecule. I bind on the barbiturate site, and it opens. I'm benzo. I bind on the benzo site, which is allosteric, nearby to the GABA site. But when I bind on, what happens? Nothing. Until GABA comes. And then GABA is like Schwarzenegger GABA. It's super effective.
Uber GABA.
Uber GABA, yeah. Uber GABA. Not yo gabba gabba, but.
Okay,
Does that, hold on, did that answer that? Erica?
Yes, what was the word you used again for nearby?
Allosteric. Allosteric modulation is the phrase that appears, I think. It just means I'm modulating or changing the function of GABA from nearby.
I'm gonna try to ask this, but I'm gonna have to start talking first. So you got GABA receptors.
Mhm.
They're on a neuron, right?
Yes.
Okay. On that same neuron, are there other types of receptors?
No.
In some cases, there's benzo receptors. Right?
Well, okay. Yes, but they're all on the GABA receptor.
How many GABA receptors are there on a neuron? 1 or 2, or 500,000, or 1,000?
Something less than all the grains of sand. I'm sure.
But a bunch, not like
Yeah,
one.
no, it's not one receptor. No, these are molecule-sized. They're protein hunks.
So on a neuron, are there GABA receptors as well as dopamine receptors and serotonin receptors and all that stuff? Or are neurons one flavor specifically?
They're not exclusively one flavor specifically. They're one flavor specifically in terms of what they release. You can have a neuron that's sensitive to multiple neurotransmitters on the postsynaptic side.
Okay. But in general, are they sensitive to only one kind?
They're primarily responsive to one. So the affinity, is everyone following the question? On the dendrites, where they're chemically gated channels, can you have multiple kinds of channels? And here we're not talking about GABA receptors, because GABA receptors are special. They're GABA plus benzo plus ethanol plus, but it's still one receptor. It just has all these binding sites for additional compounds, but it's still a GABA receptor. On the dendrites, yes, you can have receptor sites for more than one neurotransmitter, but the neuron is going to be predominantly responsible to something.
I'll understand that later.
Um,
I'm not asking you to elaborate. It's a personal thing.
I like the way you just told me to shut up.
That's not like...
No, it was entirely appropriate.
I was saying
You talked enough, leave it alone.
No, I was saying don't expect me to understand that right now. It's going to take a while for me to understand it. That's what I meant.
We're getting to a good place if you're willing to say, that's enough, be quiet.
I came across an interesting elucidating statement about pharmacodynamics and pharmacokinetics.
Okay.
So I guess this is a sidebar. PK, pharmacokinetics, is the effect of your body on a drug, and pharmacodynamics is the effect of a drug on your body. Would that be it?
It's, I'd have to think through and play out the, certainly it's as reasonable, you know, my pharmacokinetics, get it in, spread it around, get it out.
That gets mushed in my mind with pharmacodynamics.
Except, so what's the most important thing that happens pharmacodynamically?
Metabolism?
Binding. Okay, so I say binding, everyone goes, yep, I know what you're talking about,
You just
right?
said dynamics, didn't you?
Yeah.
Okay, I was thinking Coke.
So the most important thing that happens pharmacodynamically is, according to Clark, a drug receptor complex is formed. Okay, get it in, spread it around, get it out. What's not mentioned?
Binding.
Binding. So anything that modulates, changes, affects binding is going to be a pharmacodynamic process. I increase the number of binding sites. That's good. I develop new liver enzymes that destroy ethanol. Yeah. Does that help?
Does that actually happen?
Which?
The liver thing?
Yeah. Yeah, that's part of why your liver gets stressed and starts to have this disease. So yeah, ethanol trashes the liver.
So folks, occupancy,
Mhm.
third, it says the max possible response is achieved when all the receptors are found in a complex.
Yeah,
right?
and I,
So how does that apply to barbiturates and ethanol? They can continue to have that response when all the receptors are found.
wait, okay. So Occam's theory says, and I probably changed the wording a number of them inappropriately to confuse some folks on test one, but we'll deal with test one later. Okay.
So when we, well,
The respect is maximal when all the receptors are filled.
right.
Okay, and you get a bigger response if more receptors are filled, right? So, if I have 10,000 receptors, I'll get the biggest response when all 10,000 are filled.
Yeah.
But it will be a smaller response than if I fill 20,000. That was a point of some confusion. Folks went with the ratio. How many of those possible, the closer I get to 100%, but anyway, we'll deal with that. Okay, so your question is, if you get a bigger response from more receptors, how does,
Well, so if we're saying that barbiturates can open the GABA receptors if there's no GABA there, are we assuming that all the receptors are filled and then like there's still more, so it's
so the maximum barbiturate response you'd have is when you're operating on all those barbiturate binding sites on all the GABA receptors. So it's still limited by the number of receptor sites. It's just, it's not dependent on the presence of GABA molecules. So I could, okay, here's the experiment we could do, I think. Suppose I had a compound, and I'm sure I could find one, that is, ooh, you're going to like this. Pharmacokinetically antagonistic to GABA. Figure it out. What is this compound probably going to do?
It's pharmacokinetic.
Pharmacokinetically antagonistic. Or maybe I should say inhibitory. What would it have to do if it's pharmacokinetically shutting down GABA? Destroy it, right? Cause you to metabolize GABA, destroy it. So what am I doing to your GABA levels? Driving them down. So what would that do to the dose response function to alcohol?
Increase it.
GABA, you don't need GABA then.
What would it do to the dose response function to barbiturates?
GABA.
What would it do to the dose response function to benzos? Flatten it. Did everyone follow that? Okay, so let's imagine that I have this compound. I'm sorry, I don't know off the top of my head. I can find it, but and it destroys GABA. With me so far? Okay. So if Andrew, I'm going to do what I say I never do. Low to high dose of ethanol, baseline dose response function for motor activity. is I increase the dose of ethanol from low to high of ethanol, normally, what would happen? Okay, dose response function, right? For the sedative, whatever. So now I give you this compound, and it destroys all your GABA. Dose response function to ethanol is going to be?
Should be the same.
Yep. Why? Because you don't need GABA. If I did the experiment with barbiturates, it'd be the same. But with GABA on board, and when I destroy your GABA, why? Because you got to have GABA. So somehow in my head that got to your question. I'm not sure if it did actually, but
Enough.
somebody asked a question that made me think of that. But it's a cool thing to think about. There's a way you could sort out the fact that ethanol and barbiturates are GABA independent, though they got to have GABA sites, and the benzos are GABA dependent.
So
Wish I thought of
GABA,
that sooner.
is GABA endogenous?
Yes.
Okay, where is it made and how is it
In the
made?
cell bodies of GABA-releasing neurons.
And are those the same neurons that have the GABA sites, or are they different neurons? They're the same.
They would be in the area of neurons that have GABA sites because you make it and release it near neurons that will bind it.
Are there any things nutritionally that enhance or support GABA production, or the opposite of that? And if that's,
Yes.
okay, if that's outside the scope, that's fine of this class.
Does your stuff do that?
That's what it does.
Yes.
What stuff?
Bacteria.
In yogurt after distillation cyanosis, it can affect your GABA levels.
In a positive way?
In a way that if you're suffering from depression or anxiety, it messes with your GABA levels, right? So it'll return them to normal levels.
Cool.
Yeah.
What was it
Active, yeah.
It ain't what you know, it's who you know.
Lactobacillus
Microbial what?
rhamnosus.
Rhamnosus, okay. Oh, that helps. you-
On the other hand, don't go licking rancid food to get the bacteria. That's not the
That's a
good
good
stuff.
immune system.
Yes.
We have understanding, because we have two kinds of beta carotene saying one is blocked.
I think he just likes hearing you say it at this point. I can't even make
Hold
out
on.
the second word.
Yeah, I mean, I
It's like
can't.
rhamnosus.
Some of them do, the ones you got to refrigerate, read the label.
There was a paper that came out years ago, and they did it today.
Yeah,
And they
it's
found
one of
that-
the few that they've tested and validated, but you still don't hear about it much.
Yeah, it looks like it's probably they found out that it works with your brain because they removed that from like mice and rats and no effect whatsoever, but those that had the beta.
Okay, help me with the context of your question, because I'm not remembering two beta carbolines. So what do you have written in what context?
That's really
Like, you have this, I don't know, there's two.
Yeah, that's the abbreviation for beta carboline.
Okay, and I'm saying there's two kinds of use of that. I could have looked it up, it was confusing me, but it was two different competitors.
So we only have one, like, kind of structure of a beta carboline endogenously.
I'm not remembering, and I'm not seeing it.
Maybe you just mean that one's, I mean, is one an agonist and one's an antagonist, like, to have two different effects, I don't know.
No, so,
It's so funny, like,
anybody else? Well, it doesn't matter whether they're screwed up. I'll get it straight. So beta carbolines
a couple teachers have said that.
occupy the GABA site, but are antagonistic to what we think of as normal GABA function. So they occupy the benzodiazepine receptor on the GABA site specifically. Okay. If you're exposed to beta carbolines, this is what happens. Well, what would we call someone who's agitated and aroused? be consistent with anxious, right?
Okay.
Okay, so that's what beta-carbolines do.
That's all the time.
They're your central, seems to be they're your central anxiety component. They're your endogenous anxiety component.
So there aren't.
I don't think so.
Okay, maybe I've.
No, possibly I said it wrong. I get, that happens once in a while.
First.
Okay, so if the beta carbolines,
Carbolines. Mhm.
they're endogenous, correct?
Yep.
So if they can displace benzodiazepines, then how are benzodiazepines effective?
Great question. Everyone following the question? So it says here that beta-carboline, and this was just, okay? So the statement that beta-carbolines will displace benzodiazepines, that's a statement. Is it a pharmacodynamic statement or pharmacokinetic statement? Displace from where?
Receptor sites.
That would make it a
Dynamic.
good, okay. So, that's the statement. That's a pharmacological data point. So how could benzodiazepines ever win?
Beta-carboline levels go down
Or
get destroyed,
or
get displaced again.
by,
Go with benzos.
I give you more benzos. So that in the fight for receptor sites, you've got 100 molecules of benzo fighting off 10 molecules of beta-carboline. Who's going to win? Even though beta-carbolines have higher affinity, you simply have more benzo available to occupy the receptor site.
That's why people have switches when they come off of it.
It's like
Does that make sense? So if I have more of one, I have more of the drug available to go into the receptor site, even though something else would occupy it with a higher probability, it means that's higher affinity, the weaker compound can still win just by virtue of having more molecules available. Sorry, yes.
It's like the Battle of Britain, but the Nazis actually lost. No, the
Yep.
small number of Spitfires. My question before was, what I said about the GABA, what about beta-carbolines? Where are they produced?
Well, they go to the GABA receptors.
So
Where are they produced?
Yeah. And is there any nutritional,
No idea about the nutritional stuff.
but we make them?
I'd have to check to make sure that they're produced in neural cell bodies. I'm going to make sure because they could have a different origin. I want to
But
be
we
careful.
make them as a part of our normal?
They're endogenous.
And they serve a purpose, a valid purpose for scary stuff? Okay.
Absolutely. They're involved in central anxiety response.
So have there been any links to the beta-carboline and anxiety disorders or disorders such as autism or Asperger's where anxiety is high or OCD?
I'm going to say probably. I didn't look for that because I was interested in beta-carbolines at this receptor down a whole different level from that question. My bet is you could put in beta-carboline and anxiety disorders in the search engine, and I'll be surprised if you don't get lots of hits. I mean, it says when humans are given low doses, they start looking anxious. So somebody's,
Done something.
yeah, it's out there. Whether it's atypical in people with clinical disorders, I can't tell you, but I'll be shocked if it's not.
Whenever I hear of giving somebody something that's endogenous, I always think of, well, if you give it to them long enough, your body starts making less of it. But this was more of a controlled.
This is
attack.
this is acute.
Yeah, to see what happens.
Yep.
Okay.
It's acute.
In the most dumbed down way possible, if relevant to the test, you go over buspirone and with dopamine, serotonin.
Yeah. That's a very fair question. 'Cause it's very cool, but it's also complicated pharmacology.
Use pictures.
I'm going to try. Gonna try. Andrew, I'm doing it twice in one day. Next time I say I don't do it, tell me. Okay.
that a nerve or a neuron?
Now you know part of why I don't draw pictures. Okay, signals traveling left to right. So what do we have here? Here? Good. All right. So here comes the US. And this is a dopaminergic neuron. Okay? On this side, we have the structure called autoreceptors. Automatic. So, okay, when I release dopamine, the autoreceptor detects the release of dopamine and slows subsequent release of dopamine.
From that same neuron.
Exactly. So the term I used, it's like the brakes. So as I start releasing dopamine, this thing puts on the brakes on itself. It's a negative feedback loop. So if this thing is occupied and activated, what happens to dopaminergic function? Good. It goes down. Buspirone is an inhibitor here. It's antagonistic. It occupies the autoreceptor, but does not allow it to work. So what did I just take away? How am I doing so far? We're at the right level? Uh-huh.
You probably just said this, but what normally goes in the autoreceptors? What's the
Dopamine.
agonist? Okay.
So it's sensitive to the neurotransmitter it just released. Negative feedback loop. Okay? So normally it's a negative feedback loop. In the presence of buspirone, I shut down the negative feedback loop so my dopaminergic function's going up. Okay? And this is a pre-synaptic function because it's on that side of the synapse. On this side of the synapse, I have not an autoreceptor, but just a plain old white bread receptor for dopamine. Okay? When buspirone occupies this site, which is a receptor site for what compound? Dopamine. It doesn't open the channel, right? When it occupies this site, guess what? It doesn't open the channel. Same action. So buspirone is negative. But now, when buspirone operates over here, does it increase dopaminergic function or decrease dopaminergic function?
Decrease.
Am I still at the right level? Okay. How many drug actions are we seeing? One action. Buspirone occupies a dopaminergic binding site antagonistically. That's one action. Right? It occupies it negatively here, occupies it negatively here. One action. However, the action on this side has what effect? It increases function. The action on this side has what effect? Yep. So far, still good? So, ready for the last piece? These sites have very high affinity for buspirone. So if there are molecules of buspirone around, where are they probably going to go? Presynaptic. So at low doses, what am I probably going to see happening to dopaminergic function? Because the available buspirone is going? Eventually, I will reach a dose at which there's enough buspirone available to go to postsynaptic sites, and then what happens? This is for dopaminergic function. Now, there's a big step from dopaminergic function to behavior, affect, and other things. But at the level, at the cellular level, this is what we're going to see. Buspirone is initially a dopaminergic agonist at low doses. At high doses, it becomes an antagonist.
And when you use the term dopaminergic function, specifically you mean the release of dopamine?
Yeah, so I'm going to measure that with things like how many nerve signals do I see in dopaminergic neurons? That would be a function of dopaminergic function. So initially, those neurons are firing more often than less often. How much dopamine metabolized do I see? Because the only way I would metabolize it is if I squirted it out and you got to tear it up in the synapse. Initially, metabolite levels go up and then come back down. Those are all indicative of the dopaminergic neurons changing their activity in some way. I know you guys are getting tired of me saying this, but I really, I want you to think about me putting that on the board and saying that 3.5 weeks ago. It really would have been Greek, right? Okay, I need to give you that feedback once in a while, because I know your head's hurt a lot. Okay. I'll stop giving you positive feedback.
We want candy.
Okay.
That just controls the calcium that flows into the cell, right? The auto.
Yeah, autoreceptor. That's the final mechanism of action. So the autoreceptor is going to slow the influx of calcium, reduce the amount of neurotransmitter released. That's how I hit the brakes. Okay. Okay, serotonin, 5-HT. On the presynaptic side, the autoreceptor normally does what? Hits the brakes. So if I give you buspirone, it is agonistic in the autoreceptor. So for serotonin, buspirone would be presynaptically, it would be an
Agonist.
Be an antagonist.
buspirone operates the autoreceptor. The autoreceptor is the
Negative feedback brakes.
brakes. Therefore, buspirone would do what to serotonergic function? Shut it down. On the postsynaptic side, buspirone occupies the receptor site but does not open it. It's agonistic here, it's antagonistic here at the receptor site. If it occupies the site but does not open it, it would do what to serotonergic function? Slow it down. So for serotonergic function, as I increase buspirone, what's going to happen to serotonergic function? Because it shuts it down over here with one action, it shuts it down over here with a different action.
How's it shutting it down at the pre? Do that again.
Okay? Buspirone activates the autoreceptor.
Activates. Oh, okay.
It's excitatory at the autoreceptor. The autoreceptor then does what?
Brakes.
Hits the brakes. On the postsynaptic side, it's inhibitory, antagonistic, whichever word you want to use, which means I just shut down the signal. High levels of serotonin, High levels of serotonergic activity are associated with feelings of, yes, anxiety. Thus, buspirone seems to be doing what right here? Decreasing serotonergic activity, reducing anxiety. This is probably the anxiolytic component right here. So you could say, why the heck did you make me learn the dopaminergic part? Because it's really cool. But in terms of making your anxious client feel better, this is important.
Does it matter where buspirone has a higher affinity for serotonin?
I didn't see a reference to differential affinity pre and post for the serotonergic neurons. I mean, there probably is one, but I didn't see a specific reference to it in the paper.
So does it matter on the dosage for this one if they both have the same effect?
No, because
Want it to go to the postsynaptic versus the...
good point. Doesn't really matter. Wherever it goes, what's it going to do? Shut it down. Shut it down. Cool. Shut it down. Okay.
But it would still affect the dopamine at the same time, correct?
Yes, it is affecting dopamine. So if you could keep levels low so that your dopamine levels went up, since sometimes higher dopamine is affiliated with more positive affect, that might be good.
But if you went too high, even if you didn't care that it switched that serotonin,
Your anxiety's down, but now you're,
depressed.
well, you're not necessarily depressed, but you're probably dysphoric. Well, that is depressed. Sorry, well, no, dysphoric and fully depressed is just you're affectively flat. Okay, last, just to finish the story. Am I doing okay so far? Okay, last piece. You take buspirone, you metabolize it into
It's that weird dopamine mode.
I wanted to make sure before I said it. Piperazine. Piperazine occupies adrenergic sites in the periphery. This is easy to remember. Adrenergic sounds like? If I dump adrenaline in your body, you experience high levels of arousal. Pulse rate goes up, all that stuff. Piperazine occupies those sites. Anybody want to guess? Agonistically or antagonistically? Antagonistically. Therefore, it's harder for your body to have an anxiety arousal response. So, yes, you see the bear, but it neither frightens you centrally or peripherally. And the difference, because we've had a couple of references in the past to beta blockers, instead of occupying beta adrenergic sites, piperazine's occupying alpha adrenergic sites. But I think we're okay. There are differences, but it's still helping with that peripheral sympathetic response. You're not having your fight or flight response. At least not in the periphery.
So high levels of that wouldn't create a parasympathetic response, it'd be more like neutral.
Good question. Normally, the feedback loop would suggest that as sympathetic goes down, parasympathetic would come up normally. But I don't know if this case that would be true. I don't have an answer. Great question. I don't know that I could use it to put you to sleep. I could certainly use it to have you not be alarmed.
Right.
Those of you that give them, if you give beta blockers to someone, do they go to sleep? They just chill.
Yeah.
So that would suggest no. But you don't facilitate parasympathetic when you inhibit sympathetic this way.
So it wouldn't necessarily affect motor function.
It wouldn't necessarily.
Have to.
I gave me the necessarily to bail out on. I'm sorry, go ahead, Colin, you were saying?
Only if you were trying to run away from the bear.
Right.
Yeah, only if you needed the higher arousal and change in vascular perfusion, all that stuff that comes with
Take it
energy
before you go
stimulation.
work out.
Take it before you play golf, you'll putt better.